Welcome to Pharmacy Friends, a podcast dedicated to bringing industry experts to the same virtual table to talk about what is happening in pharmacy today, what is coming in the future, and most importantly, what it means to you. We're discussing the complex and ever-evolving nature of oncology. Over the next 5 years, oncology expenses are expected to reach $220 to $250 billion. Oncology medications account for half of the total medical benefit drug spending, with an average claim cost of over $3,151 for commercial plans. In response, oncology solutions are advancing by combining cost of care strategies with a holistic patient care approach to deliver integrated, flexible interventions that address cancer's many complexities and drive quality care and cost savings. On this episode, we're sharing insights into cutting-edge technologies and next-generation trends, contributing to the future of oncology care. Joining us on the Pharmacy Friends pod are some of the brightest minds and voices in oncology. Simone Ndujiuba, Director of Oncology Clinical Strategy and Innovation, joined by Dr. Joseph Leach, Chief Medical Officer at Prime Therapeutics. Let's get into it.
Hi, everyone. This is Simone Ndujiuba here on Pharmacy Friend Podcast with Dr. Leach, and I am the Director for Clinical Strategy and Innovation with Magellan, and I'm joined by Dr. Leach, who is the Chief Medical Officer for Prime Therapeutics. Dr. Leach, welcome to Pharmacy Friends.
Thanks, Simone. It's great to be here with you. Very excited to be working with the Magellan team, and thanks for inviting me to the podcast. Out of curiosity, Simone, I'm just getting to know all of my colleagues here at Magellan. Tell me a little bit about your background in oncology.
Actually, it started, I would say when I was in pharmacy school, but my love of healthcare started in undergrad. Just trying to figure out what I'm going to do with my life. Am I going to go into medicine? And if I do, what aspect of healthcare am I going to be in? And so it's actually when I was volunteering at one of the medical center hospitals at the Texas Medical Center that I realized that I really enjoyed being a part of the healthcare team. And when I volunteered with the pharmacy department, I realized, pharmacy was really the perfect career for me because it melded not just therapy and trying to figure that out, but it also incorporated, the clinical part with the patient piece, diagnostics, all of those things. And when I was in pharmacy school, my 4th year doing my rotations, I had a rotation at a major cancer center, and I was in the melanoma unit, and just the amount of innovation, just with all of the possibilities with treatment, that's when I really realized that, oncology was I don't want to say passion, but definitely my number one interest. And I wanted to pursue that and to really be involved in the evolution that was occurring in treatment. So Dr. Leach, what about you? What brought you to Prime Therapeutics, and how did you realize that, oncology was the route that you wanted to take as well?
I had a pretty circuitous route to get where I'm at, although my story sort of follows a little bit along yours, but I actually started out planning to be an optometrist of all things.
Oh, wow.
I've always worn glasses, growing up. That was a pretty cool job. And got to college, and actually my advisor just asked me, well, why don't you go to medical school? Which I'd never really thought of. But it seemed like I had a pretty good aptitude for sciences. And so I applied to medical school, got accepted, and planned to become an eye surgeon, sort of sticking with the eye theme. Back then, I think it probably still is, but ophthalmology was super competitive field to break into. And so I really kind of kept my head down during my 4 years of medical school, trying to sort of buff up my resume to get into an ophthalmology program. So I did match in ophthalmology, but you have to do an internship in something else before you start ophthalmology. And so I just did internal medicine. So this was actually back in the, early 90s. Very different time in oncology. And so Nobody wanted to do oncology back then. So they stuck me as an internal medicine intern on the oncology ward. I'd had no exposure to it.
Yeah.
And I loved it. It just seemed like such important work. The patients were amazing. We had probably 4 effective drugs back then, but I really was impacted by just the people we were taking care of. So I went and started my ophthalmology residency, did my first year, and I hope there aren't any eye doctors listening, but it just seemed less important. so, so after a year of that, I made the hard decision to leave my ophthalmology training, and then went back, finished my internal medicine residency, and then did a fellowship in medical oncology. So my career really has been focused on clinical care. So, I've been a clinical oncologist. Really, my background is much more research-based. So I've spent a lot of time doing patient care, spent a lot of time involved in clinical research. I was head of a large research consortium here in Minnesota, spent a lot of time working with the research bases, and then spent some time in medical leadership. So I was medical director for a pretty large oncology program here in Minneapolis, where I live. And so then, as these things often occur, it was really a relationship that brought me to Prime Therapeutics. So our CEO, Ken Paulus, and I worked together at a large health system when he was CEO. And with his background, he kind of had a different vision of what he wanted to do in the PBM space. And he really wanted to bring on a non-traditional CMO with a much more sort of patient-centric and clinical background, which is me because I have zero prior experience in managed care except for the frustration of trying to get drugs approved.
So we have that in common too. Look at that.
I know, right? So Ken sat me down, and my initial impulse was, oh gosh, why would I want to work, at a PBM? But the more I thought about it, I've kind of always felt this way, if you're not going to be part of the solution, you really can't complain about the problem. And so, I really wanted to be involved with understanding why the system is the way it is and being a voice for the people who are most impacted by the work we do, which is, the providers and most importantly, the patients who need the services we provide. So, so I've been here at Prime for 3 years. It has been quite an education, and this world is far more complex than I ever imagined. I always imagined it was complex. And I've maintained a part-time clinical practice. So I have a part-time practice at the University of Minnesota system here in the Twin Cities. And I really find that combination to be useful because it really keeps me grounded. It's funny. So when I was in clinic yesterday, Mondays are my clinic day, and I actually had 2 letters from Magellan RX telling me that they'd approved. They're good letters.
Okay.
But it really helps. It really helps in my position at Prime to really be in touch with what it is like for both patients and providers on the front line. So it's been a great combination. I've learned a ton. And continue looking for ways to find solutions to all the challenging problems we face in healthcare.
Yes, I absolutely agree. And I can definitely relate, as I mentioned, being on the other side, being in clinical practice for 15 years as I had been, and kind of receiving these prompts for, more medical information, more proof really that the treatment that we are using for the patient is actually supported by evidence and things of that nature. So at times it can get frustrating, I think, really thinking, at least at the time, I'm thinking, well, of course we're doing the right thing. Of course, we are using the most, guideline supported, evidence-based therapy for our patient. But we do know that things are changing rapidly. Oncology is evolving. I feel like every other month there's a new 1 or 2 or 3 new drugs coming out for any given indication. Right. And so, it's changing so quickly. And I really enjoyed your story about just how you evolved and found your path into oncology. So what are your thoughts around just some of the innovative things that are coming out? We now have, really knee deep and really having precision medicine be part of our day-to-day, I think, in oncology. And I think that was the goal. I remember reading an article probably, 5 or 10 years ago about, tailored medicine, where it's precision medicine, where it's, patient-specific medicine. And at the time, we're still given, as you said, just a handful of drugs for patients and kind of slowly moving into this new realm. So what are your thoughts about, targeted therapy and just all of the evolution that we've seen in oncology as far as really making our therapy much more specific to our patients.
I started practice back before we had what I would consider, now sort of this modern era of oncology where we have much different kinds of treatments. So you probably remember back in the day, we had drugs like cisplatin, paclitaxel. I remember when Taxotere was sort of the latest, greatest, amazing drug, So we evolved from this world of just different kinds of cytotoxics that we would throw together in different combinations and find out like what is the absolute highest dose the patient could tolerate, to, this modern era where chemotherapy is becoming less and less important. And frankly, having fewer and fewer places in the modern therapy of cancer. And that's really because of the changes that have occurred based on our understanding of the biology of cancer. So, really the two biggest changes I've seen in my career that have fundamentally changed the way we think about and treat cancer, targeted therapies was the first. And, a lot of the things that I've done in my career have been impacted by patient experiences. And I've primarily focused on thoracic oncology in my career. It's funny, when I started out, nobody wanted to treat lung cancer because it was really a hopeless disease. Yeah. And now everybody wants to treat lung cancer because it's, the most exciting disease.
There's hope.
Because of the breakthroughs we've made. Yeah, it's unbelievable how much it's changed. But, early in my career, I was taking care of a young man. This is just a horrible story. 23-year-old, never smoker who was diagnosed with advanced lung cancer. He was actually living in New York City at the time, sort of living the life, working on Wall Street, and started treatment at Sloan Kettering. Getting the best care in the world, but there just wasn't that much that could be offered to him. So he basically came back home to Minnesota to be with his family before he died, and connected with me. And back then, there was a drug that we were starting to hear about called gefitinib. You remember the old drug Orissa?
Oh, yes.
And it was being studied in Japan, and it was still experimental, but we were hearing these amazing case reports of people with lung cancer taking this pill with amazing responses, and it seemed to be happening more often in people who didn't smoke. And at the time, the only way to get our hands on it was on a clinical trial, and I desperately tried to get the study open at the institution I was at, but it took too long, and we opened the study 3 months after he passed away. And if we had the tools back then to do things we take for granted now, things like next-gen sequencing to understand the biology of the cancer, I bet there's a high chance we would have found that he probably carried an EGFR mutation and could have been one of those amazing responders. And so, we've gone from a time where we just didn't understand at all the underpinnings of biology cancer to now where, we can run 300 gene panels on small pieces of tissue and now more frequently on blood to identify what are the genetic drivers of cancer and then pair it with a drug that will specifically work for your cancer based on the genetic makeup of your drug. And so, we've gone from nothing but chemotherapy to now, dozens of these targeted oral therapies that have been incredibly impactful for patients. And so it's also made things super complicated though, right? Because we not only have to understand the medications, but we now have to understand genetics and molecular biology to be able to interpret all the complexity of these tests, because even within specific mutations, there are different variations of those mutations, some of which may tell us that a drug may be beneficial, but some which may tell us that that same drug won't work, even though the mutation is of the same family. So, to your point, it has been really fun to see these changes that have given more treatment options for our patients, but it's reached a point where I don't think a doctor can possibly keep up with not just the amount of research that's going on, but the stuff that you have to know for clinical practice. And so, trying to help doctors get the tools they need to make the right decisions, especially in our world, where we're trying to help them understand what is the best drug for that patient, is a real challenge. And I think one of the really important things that we're going to be working on.
Yes, I absolutely agree. I mean, especially in a world where, 80% of our physicians are in the community setting, and being in the community setting, many of them are really generalists where they're having to treat patients with, multiple cancers. They're not able to necessarily specialize like our physicians and our larger academic centers are able to. And so definitely having a tool that does streamline the process of knowing the test to do for a particular cancer, maybe even linking that to potential therapeutic options that are all based on evidence and guidelines and are proven. That would be tremendous. And when I was in clinical practice, that really is the golden route to take. I remember many a times we would have patients come in, they would have their biopsy done, then the biopsy or a blood sample, for a liquid biopsy may be sent out. And then once that's sent out, the results come in. After the results come in, then the physician has to interpret that testing result, understand what they mean. Is this drug going to work? Is this not going to work? Is the mutation that has a drug for it even there? Is there a drug for the mutation that was found? And then once all that's kind of hashed out, going through the process of going back to the literature and saying, okay, so with this given mutation, what are my drug options? So all this takes time. And I think definitely from what I hear from many physicians is just the time aspect of things. Unfortunately, your patient didn't have the time to be enrolled in that gefitinib trial. So what do you think as far as the time, the tools that might be available to kind of help alleviate this time that seems to extend in some cases to where physicians aren't able to start their patients as quickly as they may want?
It really is a challenge, especially, I think it's especially hard for patients. Just imagine you've just been told you have an advanced cancer, whether it's, lung cancer, colon cancer, breast cancer. You want to know, number one, what does this mean for me? But it's really important, number two, to know what is the path to treatment so we can start battling this cancer. And unfortunately, there was a time when all I needed was just a diagnosis, and that's all we needed, but that's no longer the case, right? I mean, we really need to have the advanced diagnostics to make the right treatment decisions. And to your point, it can take a long time. And it's also complex because it really has to inform the kind of biopsy you get. I've got a patient I saw yesterday he's got a lung mass and he's got cancer in his bones. And unfortunately, his lung mass is in a place where it's very difficult to get a biopsy. We tried to do a biopsy through navigational bronchoscopy, and we didn't get enough tissue. So this is a challenge we often are struggling with. I don't have enough tissue, but he's got a cancer where I really need to understand the molecular biology of the cancer. And so in a case like that, a test like liquid biopsies with plasmid DNA can be crucial. And so that's going to be the next step for him. But a lot of docs, I got to tell you, don't know that that's even a test they should do. I've seen many cases where patients were started on what likely was inappropriate therapy because the doctor didn't feel like there was an avenue to get the answers to the question about what are the driver mutations in the cancer. So it's complex understanding what the testing means, but it's complex even getting to the point where you're ordering the right tests. Number one, are you sending it on the right tissue, or should you be using blood? Number two, do I need a 300 gene panel in a cancer where there are really only 3 mutations that I need to know that are going to affect, my decision making?
Yes.
And all of that, unfortunately, requires knowledge. And so your point, if you're a community doc expected to keep up with everything happening in myeloma and chronic lymphocytic leukemia and breast cancer, lung cancer, it is impossible, even if you were to read 5 hours a day, there's no way you could keep up with it all.
Yeah.
And then you have to try to explain to a patient, we're going to wait the 2 weeks it takes to get this test back before I tell you what the best treatment is, because otherwise we're guessing and we may choose a treatment that's really not in your best interest. That's a challenging message to give to a patient. And it's also challenging for the doctor not to immediately jump to the tools they know, which are often things like chemotherapy, or even worse, starting a patient on a drug like Keytruda that may be completely ineffective for them and may make it more difficult to use more appropriate therapies down the road because of toxicity. So the decision-making process has become incredibly complex, both in terms of just figuring out what diagnostics to order, but then interpreting them and coming up with the best treatment plan. And so I think, as we look at the way oncology is evolving, we just really need to think about how do we get decision-making tools to the providers to help them navigate the world they now live in.
Mm-hmm. Absolutely. And so, using your crystal ball, is there any tool out there in the horizon that could potentially meet this need?
There certainly are some things out there that some practices using more than others that I would love to see more broadly adopted.
Mm-hmm.
One of them, and it's something that I've been fortunate to have access to in my practice, are decision supporting tools at the point of prescription. And so there are a couple of them on the market. In my previous practice, we used a tool called ClearValue Plus. In my current practice, we use a tool called ClinPath. But they're basically decision support pathway tools where I, in the EMR, can load the data, staging information, pathology, and then importantly, it will ask me to enter the appropriate biomarkers. I've got to put in the PD-L1, I've got to put in, when appropriate, EGFR and ALK, all of these kinds of things. And so it's good because it prompts the docs, especially with the cancer that they haven't treated a lot,
Mm-hmm.
bladder cancer, things like that, about what the appropriate testing is they need to get, and so those things are important. And then once it's collected all that information, it advises the provider on what is, based on the algorithm, the list of most appropriate therapies for that patient.
Mm-hmm.
The cool thing is, we've got NCCN and those kinds of things we can always refer to, but as we all know, NCCN is very inclusive, and so it really
Mm-hmm.
includes sort of the universe of options. This really helps me understand not only what is going to be evidence-based, but also what's going to be least toxic and what's going to be most cost-effective. Obviously, with our hats on for Magellan and Prime, the cost of taking care of people with cancer is getting to be exorbitant, largely because of the cost of some of these drugs. Using them in the most appropriate setting is really important, but also thinking about using the least toxic and, when effective, the lower cost regimens, I think is really important. So some of those decision support tools I think can be really beneficial. I'd love to see broader adoption of those. And then the other, and this is something I know Magellan's been working on, is we really need to get help to docs about understanding how to manage precision medicine, because it constantly is evolving. I'm sure, as we all know, we're seeing now the first, ESR1 specific
Mm-hmm.
breast cancer drug, recently approved. It just shows that, it's not just lung cancer, right? Almost every cancer now needs a biomarker to help inform its decision, making. And so looking at tools that help with ordering the right testing and then interpreting the results is really important, And so one of the partners that Emma Jones has been working with, I'm really excited, to work with is Trapelo, which I think is a fantastic platform to really help with that crucial upfront decision making that docs have to make. The other one that I'm really excited about too is sort of on the back end. One of the challenges we have, especially with things like immunotherapy, is understanding, number one, who really needs it, especially, patients who may have had potentially curative surgery. And then number two, is it working? Which can be really challenging with drugs like Keytruda. And so something I've been starting to use more in practice, and I think there's more and more evidence supporting the value of this, is circulating tumor DNA.
Mm-hmm.
And so that is really looking at minimal residual disease. And so it's a blood test that gives me an idea in a patient with resected cancer, do they really need additional therapy? Because if they have a negative MRD test on blood, data is pretty strong that they're going to have a really excellent outcome. And then number two, it can tell me if drugs like Keytruda are working because that test should show decreasing circulating tumor DNA. And so I think that tools like that may also help us better manage which patients need these treatments and help avoid both the cost and toxicity in those who either don't need them or those in whom it's not working.
Yeah, I absolutely agree. As you were talking, I was just thinking about, breast cancer. Well, gosh, I trying to see maybe like 10 or maybe 10 years ago even, we're still treating everyone with adriamycin, Cytoxan, followed by Taxol
Right.
or Taxotere. Everyone got the
Right.
same thing. We didn't
Yep.
know the difference between cancers. We didn't know, okay, which patient's going to benefit from just surgery and leaving them alone, which one's going to benefit from just hormonal therapy, which one's going to benefit from chemo. And now, we know that all this matters, all this highly stratified way of treating patients and really delineating who's going to benefit from treatment is so, so important. And as you were talking about immunotherapy, and yes, immunotherapy has totally changed, I think, how we look at treating cancer and just how to manage it and side effects associated with treatment. We're not dealing with the chemos where patients are always nauseous, so highly immunosuppressed. Definitely a good thing that we have these tools available, but still we need to determine who's going to gain from it. And then also, how long do you treat? So the fact that you're using circulating, DNA, tumor DNA is phenomenal. I mean, this also has been talked about for quite some time, mainly in research, but now it seems to be becoming more and more part of the conversation as far as how to really monitor patients as they are going through treatment to see earlier signs of response and even earlier signs, unfortunately, maybe even of relapse, to know, okay, maybe it's time to start switching things up. So are there other tools that you see that can potentially help us to really better delineate? Is there a movement to really start focusing in on immunotherapy and deciding, okay, which patients are really going to benefit from these impactful group of agents?
I think that it's an area that the more we learn, the more complex it gets. Now,
Yes.
if we talk about, breakthroughs in oncology, I think immunotherapy is clearly the biggest that I've seen in my career. I mean, for patients in whom they work, and unfortunately, in the majority of patients they don't work, they can be miraculous. The problem is the way that we designed our clinical trials is we keep adding onto a backbone of chemotherapy or more intensive therapy, but have not answered the questions that I think are really important, and that's in whom can we de-escalate. So, for example, you've seen all of the studies that have come out in lung cancer. We started out with platinum doublet chemotherapy, which forever had been the standard of care, and then we saw that adding checkpoint inhibitors, drugs like Keytruda, really made them more effective. But I think we forget that there's an important study, Keynote 24, that looked at just Keytruda by itself compared to chemotherapy, and it showed really pretty spectacular single agent benefit in patients who had high PD-L1 scores. But unfortunately, we've seen some of the clinical trials continue to build more and more toxic therapies. So now we've gone from chemotherapy plus checkpoint inhibitors. Now we've gone chemotherapy plus, dual immunotherapy. The recent approval of tremelimumab with durvalumab plus doublet chemotherapy. I just think that's the wrong direction to go. I think it's important for us to ask, these are important tools, but should the default option be the less toxic therapy? And I would love us to start comparing things like single agent checkpoint inhibitors with some of these more intensive therapies, because I suspect that there's a patient population that would do just as well. The problem, we talk about NCCN, is they're all category 1. And so it doesn't really give docs a lot of guidance into which of these regimens should I choose, because obviously the toxicity with a single agent therapy versus a quadruple, agent therapy is going to be substantially different. And of course, the cost is crazy expensive when we start piling drugs like that. So, I hope that we start coming back and looking at some comparative effectiveness research, trying to help understand when we can use less effective therapies. And frankly, I think the default should be less effective therapies when we don't have strong evidence that these more toxic therapies, are more beneficial. So I think there are a lot of those kinds of questions. And the other one is, how long do we need to continue things like checkpoint inhibitors? I've got a patient, I was fortunate to be involved in some of the early phase 1 trials of a number of the checkpoint inhibitors. So I still have some patients in my clinic who were on those very early studies. So I have one patient, actually just saw him last month, who was on a single agent checkpoint inhibitor study for his widespread lung cancer. And at that time, the study called for just 1 year of therapy. I mean, because back in the early days, people with lung cancer didn't live a year usually,
No, they didn't.
So he's disease-free 8 years out after 1 year of therapy. He's had no therapy since then. It would have been easy if this were, commercially available for me to continue to treat him forever, right? And so I think that's an important question too. How long did patients who are really good responders need to continue on these therapies? And that's why I think tools like circulating tumor DNA may be really beneficial. It maybe will help us identify when we can sort of stop treating patients who no longer need therapy. So.
Right, because any therapy, even if it's, something as benign as maybe aspirin or Tylenol, in my mind, that's benign. Everything has a toxicity, everything has a side effect, there's a consequence. And we know that immunotherapy comes with its own set of consequences. And absolutely, if there's a patient that doesn't need treatment, then if there's a way to know when to stop, that would be incredibly ideal. And circulating tumor DNA, it's just amazing to me to kind of see how far it's come. And I'm excited to kind of see how we can, utilize that in practice. Do you see a growing trend in its utilization in practice?
I think docs are still waiting for more evidence. The one good thing I will say about it is it really is being incorporated into most of the clinical trials now. So a really practice-changing study in lung cancer was this Checkmate 816 trial, which looked at patients with early stage, so stage 1B through 3A non-small cell lung cancer, and they were treated with 3 cycles of preoperative therapy with a platinum doublet plus nivolumab for only 3 rounds of treatment. Had surgery, and then that was it. They didn't get any more therapy. They didn't get any adjuvant chemotherapy or nivolumab. And, we saw unprecedented responses. So the beauty of that study was we could actually see what happened to the cancer because it was taken out. And, a quarter of those patients had complete pathologic responses. But a really interesting sub-analysis of that study, because they followed the circulating tumor DNA. And in patients who went from having measurable circulating tumor DNA to clear blood, so no evidence of cancer in the blood after surgery, those patients had a very low risk of relapse. And so, I think as we see more and more of that type of data supporting how powerful the tool that can be, I think we'll start seeing more adoption. So they are commercially available. Probably the leader is a test called Signatera. And it is being used, I would say some, but it hasn't been broadly adopted yet. But I suspect it will be in the future.
Yes, I definitely agree. I think, as you said, more and more trials are including it, and you definitely see it referenced more in literature as drug development is occurring, and even within the guidelines at some points. We've talked a lot about immunotherapy, and of course, for the last couple of years, CAR T has made a lot of waves in healthcare, and specifically with our hematologic cancers. What is CAR T development looking like as far as research and possibility of using it in, let's say, like thoracic cancers, like in the area that you practice in?
Sure. Yeah. CAR T has been pretty amazing to follow, hasn't it? I mean, it seems like science fiction when it was first being developed, and now it really is become, I mean, a fairly mainstream therapy. I mean, not available everywhere, of course, but really much more broadly used. And I think there are a lot of questions still to be answered, in CAR T therapy. The toxicity, I mean, has been challenging, right? But I do think that with more experience, high volume centers have gotten pretty good at managing the toxicity. I think the question with CAR T in the spaces it's being used now, things like relapsed lymphoma and multiple myeloma, is, are we using it too late? And I think it's going to be an important question for us to answer, because everyone, of course, is concerned about both the toxicity and the cost of CAR T therapy. And you both know, I mean, it's pretty expensive therapy, but it's crazy expensive, right?
Yes.
I would argue that we maybe need to think about using it earlier, because the impressive thing about CAR T therapy is that it really provides much more durable responses. So patients where it works, we don't have enough follow-up, that we're hopeful that some of these patients are cured. But it's been used very late, right, in patients who are heavily pretreated. And so it's interesting as we start seeing more approvals in earlier lines of therapy in the hematologic malignancies, if we can really improve that durability by using it earlier in patients who are at very high risk for relapse, I just wonder if that won't be, number one, more effective for improving survival, but number two, might be cheaper. You just get it out of the way, and then we haven't wasted a lot of time and expense on therapies that are eventually going to just lead us to using CAR T anyways. So I think there are a lot of questions to answer in terms of what's the most effective line of therapy for CAR T. And then patient selection is so really important, because even though these drugs are amazing, there's still way too many patients who get it where it doesn't work, or it doesn't continue to work as long as we would expect it to. You really, I think we need to have high expectations for a drug that is that expensive and that toxic. Now, one of the downsides of CAR T is really it's only been effective in hematologic malignancies. It's really not been something that's been effective in solid tumors. There are some newer approaches to that. It's funny, we just had our research call at the U of M today, and we're actually opening a phase 1 CAR T study for lung cancer. And so there's certainly a lot of interest in the solid tumor space, but I think we have a lot of sort of basic science understanding of why it hasn't been as effective. And so I think we're still quite a ways, from having CAR Ts active in solid tumors. But I suspect, and it probably won't be all solid tumors, but I do suspect that we're going to start finding some areas of efficacy in specific patient populations, in some of the solid tumors. The other thing I'm really interested in, one of the challenges in CAR T has just been they're so complicated, right? I mean, you have to do the whole pheresis, and you got to grow the CAR Ts in some lab and try to keep the patient stable for that month while you're waiting for them to get shipped back. So we saw the first, this first BiTE antibody approved for lymphoma, a few months ago. I think that's a really interesting space too. They have some of the high response rates we see with CAR T, but none of the hassle of CAR T, right? Because they're just off the shelf. You don't have to grow them in a lab or anything. And so I think as we start seeing more of those become available, I think it's going to be an interesting question too. I mean, where do they live in our armamentarium versus CAR T? And again, what is the best sequence? I mean, are these going to be an alternative that will have similar durable responses to CAR T? Or are they not going to be durable and we're going to end up doing CAR T anyways, in which case I would argue you're better off just getting the CAR T done. Right. So I think there are going to be a lot of interesting questions for us to answer both clinically and frankly from a payer standpoint, because we want the most effective therapies being delivered to our patients that deliver the most value, so.
Yes, absolutely. I think payers are definitely looking to see what the future holds, especially as we see developments in CAR T and other, definitely expensive therapies that hopefully will, provide what we all looking for, which is sustained response and potentially a
Yeah.
cure. But Dr. Leach, I want to thank you so much. This has been an amazing conversation, and I can't wait to see how the landscape of oncology and treatments and drug development continues to evolve. And I think we can both agree that, it's so important to bridge the gap between medical and pharmacy management. As you mentioned before, treatments are getting more and more expensive, and we really do need to start looking at which patient population is really going to benefit from certain treatments and aligning those patients with those treatments and continuing to develop those other areas so that, all patients have options. And so it's been wonderful coming together, and thank you so much for illuminating on all these, possibilities and what you're currently involved with and what you are currently doing within your practice as well.
Good. It's been really fun. Yeah. Thanks so much for inviting me on. And I agree, boy, this is going to be a very, very interesting time, isn't it? I mean, some of the things that are available to our patients now, I wouldn't have dreamed of when I started this career. So it is really going to be fascinating to see what benefit we can bring to patients who've really not had effective therapies, and now they do, but also how can we most effectively get access to the patients who will benefit from them the most. And then our challenge is, how do we not completely break the budget in doing so? But I think it's going to be a lot of fun trying to dig through all this. And I'm really looking forward to working with you and your team.
Oh, perfect. We're looking forward to working with you too. This is going to be a whole new adventure. And so we'll get together again, and I'm sure we'll have plenty to talk about. So I will talk to you soon next time.
What an interesting and insightful conversation. Don't forget to subscribe and rate this podcast 5 stars. We'll talk soon.